lead us off.
All right, Catherine, thank you so much. Welcome to each of you. I'm Mark Kindy I work with Catherine in the Injury and Violence Prevention section at the Minnesota Department of Health. With me actually on day one, a couple of hours in, is Courtney Sarah. And so she and I are in the same office here in the main offices of the Health Department in downtown St. Paul. Greetings to you from across Minnesota. I was not able to be at our first gathering in October, and so Catherine asked if I might want to just give a special welcome to each of you today, and I jumped on that chance, so thank you so much. I think I've known this all along, but it has become ever more clear to me that we at the State Health Department cannot do injury and violence prevention alone. We are absolutely dependent on our work together, on the collaboration of ideas, of resources, on the cheering each other on when we are most discouraged, when it feels like there's been yet another legislative or community setback of some kind or another, when our best interventions have gone in the opposite direction. And we are dependent on how we work together, whether it's from our collection of data and analysis of the same, to our writing, to our reporting, to how we work in community and with community. We need each other. And that's really the frame that Catherine and I and our colleagues in the health department come. Our commissioner reframes that almost using those words as she leads. Of course, we're her favorite, right? Well, okay, a little egocentric, but Jan, our commissioner, really does care about injury and violence prevention, and about, in particular, working with the disability community, with folks with disability across the disability spectrum and continuum, and she's passionate about that. And so she and I connected when Governor Ventura was governor. Jan was appointed by him, and we started our friendship and our working relationship. And then she came back when Governor Dayton asked her to come back, and has stayed on. We're really thankful. This group, the MIVPAC, the Minnesota Injury and Violence Prevention Action Coalition, provides space for connection, collaboration, support, and yea, verily, camaraderie around this whole arena of injury and violence prevention. We look for methods and strategies and approaches that seem to work, and we're ready to adjust and vary those as we go along. We are wide open. We welcome small and large organizations to this group as we figure out how best to work together, as we explore our successes and challenges, questions and ideas. So welcome, Catherine. Thank you. I probably took more time and was a little more expansive than you allotted, but before you close the mic on me, I'll say thank you and hand it joyfully back to you.
That's all right. I knew what I was getting into when I asked you to do the intro, so it's all right. And I'll also just acknowledge our partners in leading MIVPAC, the Minnesota Safety Counselor here with Paula San and Aaron Peterson. And so we are happy to start this very important conversation. So just as a quick review, last month we talked about our state plan that has been created, the Injury and Violence Prevention State Plan. And with that, we presented a shared risk and protective factor framework, looking at very high level concepts that we believe, and we know through research and through experience, that if we address these high level concepts, we will make large impacts on many different injury and violence outcomes. And so this is our first meeting where we're diving into our first shared protective factor and sometimes risk factor if it's not present, health equity. And in our subsequent meetings, we'll address the other four, and those are community connectedness, built environment, economic justice, social emotional learning, And I think that might have been the 4. I went out of order, and so I got messed up. I went off script. So we're excited to be beginning this conversation with health equity. And last month, we did walk through an exercise where we really talked about what will it look like? What will Minnesota look like if we follow this plan? And I'm going to share my screen. Actually, Erin, would you mind making me a presenter so that I can share my screen with folks? All right. That was immediate. Thank you. Let me just draw this up here. And share, we can have a shared understanding of where we're going. Get to the right screen. So here's what we created last month, this word cloud that really showed that if we are able to make this plan happen, if we are all able to address these factors, here are some of the words that came up in conversation of what Minnesota will look like. There's connected, safe, equitable, which is perfect for today, peaceful, thriving, some really great words there. And then we asked, what does this group look like? What does MIVPAC need to look like? How do we need to function in order to make this happen? And here are some of the words that came up. Convener, bringing people together, leaders, anti-racist, courageous, accountability, representative. So some other really great words for us to strive to be and to and different ways that we should act together to really push this agenda forward. So with that, we're having our first conversation here. And as I said, it is around health equity. And I want to just give us all a shared understanding of what we mean by health equity. Oh no, and my second definition didn't show up. Anyway, I can explain it, but this is CDC's definition of health equity, and it has a lot of words. I'll let you all read it, but their main idea is that it's health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. And really that is a great concept, but it still is not necessarily all that it's not easy on literacy. So another example, another definition that I found is health equity means that people have opportunities based on their needs. And another real world explanation that was shared with me was thinking about when we deal with children, and if you have, 3 children in your family, they may not all need the same resources to thrive and to grow. One may respond better to book learning, and so you provide them with books, a library card, trips to the library, but another child may be much more, need more emotional education. So you really talk with them. You make sure they're in play groups. You make sure that their emotional needs are met. And the third child may respond best to the arts. And so you get them involved in dance or gymnastics or movement so that they can use their body and their artistic mind to really learn and thrive. So it's really looking at where the person or the community has a need and meeting them at that need to allow them to reach their potential. I thought that that was a really tangible explanation. So I invite you, while we have this conversation, we have 2 great panelists to share their experiences. And as we listen to their thoughts, I invite you to think about how can each of us address this topic? Who do we need to work with? Who is not at the table? Who's at the table? What are the 2 most important things that you want to do right now that you have the capacity to do? And then what are the next 2 things that you want to do but need more or different resources to achieve? So whether that's money, time, people, or a different type of resource. So we have 2 fantastic panelists today. Devaney Schmidt leads Health Partners work with Harvard, designing implementation of safety and well-being solutions through their total worker health framework. Health Partners is based in Bloomington and aims to improve health and well-being in partnership with their members, patients, and community. And we also have Julie Guidry, who is the Executive Director of Upstream Arts, a nonprofit located in the Twin Cities that uses the power of the creative arts to activate and amplify the voice and choice of individuals with disabilities. So I'm going to stop sharing my screen so that we can all see our panelists. And then after we listen to them, we will have a discussion. Let me stop sharing here. And so I'm going to invite our panelists to answer a series of 3 questions that we've developed. And we'll have them go one by one, but I invite them to also engage with each other if they have questions for each other or challenges or, whatever may come from this. And we can use the chat. I'll try to watch the chat. And if I can ask my colleague, Christina Monroe, to also manage the chat, that would be super helpful. Because I think we would like this to be engaging. So I will start, and Devaney and Julie, please correct me if any of what I just said in your bio is not correct. But I think we can start with our first question, and that is, how have you seen, or how do you see health equity as an injury and violence prevention tool? We didn't assign who was going to go first, so I'll let you jump in if you'd like to go first.
Oh, go ahead, Devaney. I was pointing towards you. You're like, after you.
I thought you were pointing toward yourself.
No, thank you.
All right. So Catherine, your introduction was perfect. It's exactly the work that I do. So Health Partners, we're a health plan. We're an employer. We employ 26,000 employees, as well as we have care delivery. So we're kind of representing a lot of different areas. And when we think about health and equity, it really, your definition that you gave, it really drives us to think about each of our patients, our members, and our employees and their unique situations that they're in. Excuse me. So we have a diverse set of patients that come into our clinics. We have a diverse set of employees that work with us, and we need to be thinking about their own unique situations in a way like, how do we work with them? How do we address what they may be bringing to work with them? So some of the work that I've done with Harvard is about, with total worker health, looking at root causes of things and, why are we having injuries or accidents happen at work? Well, people are bringing their authentic self to work. That could be issues at home, sick kids, maybe, it's hard for me to make ends meet. So when we think about health and equity, how do we connect those people with the resources that they need to be able to bring them their best selves to work, or get connected with, whether it's health literacy, food insecurity, housing insecurity, because we can't expect people to walk into our doors and say, I'm here to work, I'm 100% ready to go. They're bringing all these other things to them, whether it's in the hospital, the clinic, the plan. And at Health Partners, we work with Medicare and Medicaid participants, but we also work with the commercial employer groups. And we have seen, starting to get our commercial employer groups to understand that they have health inequities at their workplace. Just because somebody's employed doesn't mean that they can make ends meet at work, or they know what health plan to pick, or all those things that kind of surround health inequity. We were really surprised when we started to ask some of those questions we have a health assessment. How are you able to, get enough food to eat on a regular basis? And if 30% of people who are employed are answering no, employers didn't realize that they had those individuals sitting in their seats, and how do we connect them with some resources? I can talk a little bit more about how we do that in some of the future questions, but I think it's really the consideration of understanding who's walking through your doors and treating them, as individuals. One last thing I'll share with this question is, when we think about the people that we're working with, a couple of years ago, we did a poverty competency training with our staff and our employees. And the presenter reminded us that the way that we say things really matter. So we work with a lot of people who need to take medications. And if I'm a provider and I say, make sure you take your medications with 3 meals a day. What if I can't have 3 meals a day? So now I'm not giving that person the best that I can be. I need to say and change the way I say something to be, you need to find 3 times a day where you can remember to take your medication. And so even reframing how we say that and then kind of the downstream impacts is really important. So I would say that's our way of approaching how this tool or how health and equity can be used as a prevention, injury and violence prevention tool.
We align in so many ways. Thank you, Devaney, for the presentation. And you know, for an arts organization and healthcare provider to see that alignment, I think one of the things that we recognize as an arts organization that has a particular focus working with and alongside folks with disabilities is that we must really look at health equity as this injury and violence prevention tool specifically as an everyday practice. So Upstream Arts is an organization that works with and alongside folks with disabilities, and we leverage this sort of creative artistic practice to teach social skills, communication skills, vocation skills, healthy relationship skills, and actually to build spaces and places for our community to come together and practice what it feels like to have a healthy, balanced relationship. And so when I look at the work that we do that I think not only can exist just with us, but can be expanded throughout, I feel that what we know really specifically is that individuals with disabilities has been dehumanized. And in that dehumanization, a process, that experience results in, I think, generally a lack of creativity and a lack of curiosity when it comes to working with and alongside individuals living with a disability. And specifically, when I mean the dehumanization, I think that we have a shared narrative and collective thought that folks with disabilities can't or do not want or do not have an interest in having intimate relationships, that folks with disabilities are asexual, and that individuals with disabilities don't have an ability to be able to receive information and understand how to develop and practice their own bodily autonomy. And as a result, we have created what we know to be true as an epidemic within the disability community, and that is that folks living with an intellectual disability are 7 times more likely to be sexually assaulted in their lifetime. And some of the work is done, you know, in obvious ways through prevention of and by creating and providing opportunities for education. And that is the lane that we as an organization practice. But I think that beyond that, our advocacy work comes from saying, what are the ways that we are all responsible to the small moments of exchange and curiosity that we have with each other every single day? And how do we build a practice of recognizing and not immediately assuming the ability of somebody based on an old narrative or a tied narrative or a reality that we're bringing into the space when it comes to working with and alongside folks with disabilities? I think that health equity comes from and starts with the individual person and practice as much as it is about being responsive to the individual that we're providing a treatment for or working with or alongside. It begins with us as individuals saying, what are the practices that I need to have to assume ability of the community we're working with and alongside. So the work that we are doing is not only about using this creative practice, right? But in that creative practice, what we have found is that we have built in a practice of being flexible. And when that practice is availed, I think on the front end and as a part of everything that you do, I think it affords more opportunity for creativity, and it really builds the space for us to be curious about one another. So I think this narrative that folks with disabilities are you know, in need of or need to be supported or need to be cared for, right? We build these spaces of learned helplessness, and we create the experience of compliance versus a willingness or a recognition that an individual is going to have an individual choice. And so I think that there's all sorts of great strategies that we can have that are out there, but I think the thing that we practice the most is these small moments and this acknowledgement of an everyday practice that also suggests that, it's not about perfection. It's about creatively collaborating to understand how we come together to find solutions. So.
Thank you both for those great thoughts on that. And what really struck me, Julie, is your use of the word practice, and that gives space to try and make mistakes and learn, and then try it in a different way the next time. And I think that that's such an important concept to remember when tackling some of these big factors that we've written into the state plan, health equity, and these other big ideas that we're hoping to address, is that, you know, we need to try things, and we need to be open to some level of failure so that we can learn and redirect and go in a different direction the next time for hopefully a better outcome. So I appreciate you using that word in so many different ways. The next question that we have is, what's one or two of the main principles of health equity that you feel ground or guide your or your organization's work?
That's me now. So some of this is going to overlap. It's kind of hard to separate the questions, but I think I'll focus on one principle today, and that's really that kind of that platinum rule. So treat people how you want to be treated, whether it's as an employee, a patient, or a member. And I think that really means listening to them, understanding more about their own unique situation, asking, like, what are your barriers to success? How are things getting in the way, whether it's in your work or your personal or your home life? And I think, like I mentioned before, understanding that people are coming in from all different places and bringing, different experiences with them, that understanding their own unique circumstance really helps. So in my line of work, I primarily work in the health and well-being space and the worksite health space. And, some examples are telling someone to be physically active because that's what the guidelines say. You must be physically active, right? You must get 150 minutes of physical activity. But what if they live in a community where they don't feel safe walking in their neighborhood? Like that's not treating that person in a way that is going to be helpful for them when we think about moving them forward, or, whether it's an injury and violence prevention or their own health and well-being. Or same thing, similar example could be telling someone they need to make sure they're getting 5 fruits and vegetables every day. Yeah, that might be the guideline, but what if we're just hoping that they actually get enough food so they don't feel hungry at night? So understanding that unique circumstance or that unique person is so important for us moving forward. Getting to know them, whether it's what do they need help with, connecting them with relevant resources, that's how we can have a positive impact on injury, violence prevention at the workplace, at home, across the board. And the beauty of it is, it doesn't matter where these people work or where they don't work or where they're coming from. We all can take a little bit piece apart and understand who they are. So, finally, I think really seeking to understand the root cause of an issue and not just the kind of the obvious thing that's moving forward. So if you can do so, and you can kind of get, we all kind of have a good understanding of, going upstream and figuring out, well, why is this happening? What can I do instead of just treating the end result of what we're seeing? Like, then we can have a lot broader impact, because we're not just trying to treat what's at the end of the river, so to speak. We're going upstream to figure out why people are falling in or what may be happening upstream.
I think that, how do we consider ways that we can remove these sort of obstacles to health? And I think there is this significant barrier of powerlessness when it comes to folks living with a disability that I think gets reinforced on an ongoing basis. And I would say that one of the practices that we have as an organization is universal design for teaching and learning. It is a practice that recognizes that we have to consider the extensive nature of who are all the people that are going to be working with and alongside us, and how do we plan before they ever come into this space, and ensure that once folks do come into this space, we remain flexible and creative and responsive. So I think that there is this gap in our communities for people to be able to tell their own stories. And so as I consider some of the components of health equity, how are we ensuring that people get to tell their own stories and share their own narratives, and have alternative ways beyond verbal narrative to be able to share, show, and tell who it is that they are and what it is that they want us to know about them. It's certainly why I think an organization like Upstream Arts really looks at leveraging that creative practice, because we find many alternatives for sharing our stories. But if we consider it from a health equity lens, I think that as we regard or find that shared language, how then can we extend that shared language into the care and into the supports and services we're providing for folks when it comes to their health journey and health experience? So I think that some of the places of that that we see significantly showing up is that folks with disabilities don't have that bodily autonomy, right? And it's not because it is something that cannot be practiced or developed or learned. It is because the community that works with and alongside in many instances hasn't created spaces to support our community in a way that helps to build not only communities and cultures of consent, but also spaces where we practice building those skills of bodily autonomy. And so I think when in the absence of all of these pieces, it all leads to this sort of injury and violence that can be perpetrated against folks with disabilities. And I think these everyday practices, again, and remove are ways that we can not only build in people building that self-determination and bodily autonomy, but it's also a way for us to build the power of the individual to be able to and have and lead the most self-determined life as they possibly can. So I think that what we know is that so often the majority of choices for an individual living with a disability can be made for them on a daily basis. And so we spend time practicing supporting individuals in making choices and recognizing that your power comes from not just your yeses, but also your nos. And our power collectively together comes from us recognizing and understanding and finding a shared language for what your yes and what your no is. I think so often those basics of everyday give and take communications have been eclipsed or forgotten or not practiced in a space. And I think that when we're thinking about not only just sort of determinants of health, but also thinking about how we're supporting the diversity of members in our community, we're really responsible for finding those individual relationships that allow people to share, show, and tell not just their yeses and nos, but their own story.
Wow. We chose the right people to come and talk today to give us new ideas and new ways of thinking about things. And I'm furiously writing notes over here. And I started to just write some words that were coming out. Again, that first word of practice, but now I've added curious and listening and asking. I heard both of you talk about being flexible and responsive. And then just really hearing this idea of building the space to allow for that flexibility and building the space to allow for that curiosity, and having that be a real form of allowing health equity to develop. And then, yeah, wow, this idea then of this shared language for yeses and nos, I think is really powerful. So, wow, okay, my brain is exploding. So I'm sure that others are having, light bulb moments too. So now we're on our third and final question before we'll open it up quickly for a couple questions maybe, and then some group discussion. What is a piece or two of advice that you can share with an organization just starting to look at health equity practices, or just looking to explore focusing on health equity more consciously?
Yeah, so I think that theme of how you get to know the people that you're working with. I mentioned kind of that health assessment is a way that maybe we gather information, but that can look different across, every organization. So getting to know who your people are, but then I think secondarily, what are you going to do with that? So if somebody comes to you and, in any of the realms of health and equity and shares information and you're like, oh, okay, now I know that about you, but they're likely going to want to have support to help address whatever that health and equity may be. So whether it's connecting to resources that are available at your location, or you as an employer, or state resources. We utilize a resource called NowPow. It's called Unite. It will be called Unite Us, where people can find information or, you know, resources within their own zip code community. If I'm looking for a food shelf, or I need help transportation to an appointment, or whatever those cases could be. You know, utilizing an EAP service if your employers have that. Those are resources that are tangible that you can guide and connect people to. People are going to want support for if they're willing to share, right? And they're in this space, they're going to want support. And all of this really leads back to engaging all of your employees to address those safety risks that might be at work. So I talked a little bit about my work with Harvard and designing those total worker health solutions, but the best outcomes are really going to come from when employers find a way to address those root causes. That could be anything from slips, trips, and falls, all the way up to how your people are showing up to work, or how they were treated at the doctor the other day and maybe didn't feel like they were listened to. So becoming champions for who you're representing as an employer is really critical, because that's going to have a downstream impact on how people are showing up to work and the outcomes that you're going to be able to have. And then, you know, the greater good of all the work that, you know, Catherine and team is putting together as we think about the outcomes we want to achieve.
I again, there's sort of continued alignment, right? I think that as an arts organization that has had for the past 17 years a practice of working with and alongside folks with disabilities to teach social skills, emotion skills, learning, you know, communication, group participation skills. At some point, we started to develop programming that worked at really addressing sort of this significant epidemic of sexual assault and violence being perpetrated against individuals with disabilities. And what we found is that the practice that we had related to building and teaching consent within the classrooms, particularly for this particular curriculum and this kind of class that we were teaching, actually was important for us to expand across every intersection of the organization. Consent being something that we are really working to build as a practice organizationally. We're really working to name it as an everyday working relationship. And it is something that we hope and plan for to see in every single one of the classes and relationships that we have. So I think, you know, I mentioned earlier that universal design is this sort of practice that we have where we work to really plan before anybody gets in the room. And then once folks are there, we remain flexible and creative and working together to be able to come up with solutions to really support the individual human beings, right, that are in front of us. I think, again, that dehumanization of folks with disabilities and that singularity of narrative of like, you are a person with a disability and that is your entire identity, I think really can be disrupted in the practice of sort of doing some planning beforehand and then embracing the individual sort of personality as folks come into the space. But I think related to that, I think that building of consent in all of the different spaces that we have as an organization, I think is one of the ways that we've really looked to address health equity practices, not just in the work that we're doing externally, but the work that we're doing internally. I feel really strongly that individual relationships are going to create a collective impact that can build to sort of change within our communities. And I think that for an organization like ours that has over 100 partners annually, that works with over 4,000 individuals on an annual basis, when you start building in consent as everyday practice, whether or not you're teaching your sex positive sex education curriculum in that class, actually you are moving the needle in a way that I think is relevant, significant, and important. And it doesn't require a whole system and a whole new initiative in order for us to implement it. It's just an everyday practice that we're implementing in there. And so that's been a piece that we've really looked at saying, we're going to bring this in. We're going to just talk about it and name it. And then really work to afford it this space and place to acknowledge the human experience that lies within all of us. Yeah.
That's great. Thank you. Those were a lot of good tips on how organizations can start to think about it, both in small ways and in big ways. And again, I like that, you brought back that word of practice. You just, putting it into place, trying to do it as much as you can, wherever you can. So thank you so much. We're pretty much on time, so this is great. I do want to offer a little space for people who are attending. If you have questions that you would like to pose to our speakers, I think maybe we have time for 2 questions, and then we'll go into a group discussion about what we've just heard. So if anybody has, oh, go ahead.
Oh, Catherine, there is one question in the chat from Paula, and it says, how are we getting upstream and teaching health literacy and self-advocacy in the secondary school systems?
I don't know if either of you have experience with the secondary school systems and can address.
Yeah, all of our work is done within our public education system from birth through the age of 21 for students receiving a special education service of some kind. The trick with doing, I think a lot of this prevention work, and as we work with in the Department of Health, is that Paul, I just want to make sure you're asking about upstream solutions versus upstream arts, because it's just an unfortunate sort of alignment of our names that I think it's a little bit confusing. But I'll just answer in that one of the things that we know is that the state of Minnesota does not have a comprehensive sex education program. And if schools, arts seem as a vehicle for solutions, for sure, Paula. Yeah, thank you for that. What we also know is that as schools make plans to implement health education curriculum, often what they are doing is making plans for the regular education students and not ever thoughtfully planning for students receiving a special education service through either the purchasing of the curriculum that they are bringing into the district or the acknowledgement that there is a significant and absolute need that students with disabilities need this education. So what we found ourselves doing is actually just saying we're going to do it ourselves then. And it's not because we have a particular expertise, but we do have a skill and practice in being able to collaborate amongst community settings to be able to bring what we know are gaps in educational services for, with, and alongside our disability community. So we partnered with a number of different organizations. We facilitate classes right now with Annex Teen Clinic and our teaching artists. We've written our own curriculum that we're bringing into the school spaces, and we're really pushing to influence our school districts to be thinking about, first, we ask the question, what is your sex education curriculum? And what are the accommodations or modifications you're making for students receiving special ed services? It often leads to the next question, and that is, are your students that are receiving a special ed service receiving this curriculum? We actually ask it in the context of, at what grade level are they receiving this curriculum? Just interesting to see how they are responding to these questions, and not as a means to call people out, but as a means to invite people into a dialogue and into a conversation for how we can come together in solutions. I think, Paula, this all aligns with the work of self-advocacy. I think when we talk about bodily autonomy, one of our lessons is my body belongs to me, and to be able to be not only an individual personal self-advocate, but a sexual self-advocate I think is an essential and critical tool for every single one of us, including individuals living with a disability. So that's how I would, in response to that. I'm seeing a couple other things in here in the chat too, but I'll let Devini, if you have thoughts on this too.
So I see one other question here. It says, more for health partners than upstream arts. Hearing that one's own employees face food, housing insecurity feels like an opportunity to discuss what equitable employment benefits look like. Do you find that a simple answer like paying more is a plausible solution to increasing equity?
That's like the $1 million question. I mean, we started asking these questions in January, and we usually wait until we have 8 months of data to, bring back to our employers when the majority of people have engaged. And so we are just now engaging in these conversations. And the surprise, whether it's health partners ourselves or the clients we're working with, is paying somebody more seems like the logical solution. Probably not as easy as that as we think about business practices and all that goes along with it. But starting to ask some questions about, wow, what area, like, there's more to it. We could have people who are their sole providers, and how do we support them in flexible work environments? So it's such a not fascinating. It's actually not fascinating. It's sad, right? We don't want people to be not able to afford food and housing and all of those things. So we are deep diving with our HR team right now to figure out where do we start? How do we begin to think about, with 26,000 employees, but remember, we're 17 single separate employers as well. So what does that look like for Park Nicollet employees or Hudson Hospital employees, and are there things that we can be doing differently? The tough question.
Yeah. So this is probably one follow-up, and then we'll go into our discussion. But Paul is asking, where does financial well-being education fit into the workplace? Also, maybe something that is being discussed.
Yeah, I mean, and it's, when you think about overall well-being, financial is always a big component of it. And we're seeing in the industry that a lot of your 401k providers and others are starting to get into the space about providing that financial education versus us creating something homegrown that we can provide to our employees. So it's really more about pulling in those resources from your EAP that can provide some financial planning, or your 401k, or those providers who have expertise in this space. Is really where we're lending ourselves to think about, let's partner with them versus starting from scratch. You already have good information, and then how do we get those to our patients, our members, our employees? That's the lens that we're taking. Others might have a different approach, but that is definitely the kind of the direction we're going.
Great. Thank you so much. As I said before, you both gave us so much to think about, and I thank you so much for being a part of this conversation and really leading us in thinking about the different ways that health equity can be used as a prevention tool, and how different organizations can support health equity in their workplaces and then in their community, like you said, trickling out. So I emailed you both before. You are more than welcome to stay for our conversation, but also we understand time is very limited, and so we appreciate the time that you have given to us, and you don't have to stay. But at this time, I would like to have us start to think about this in the context of Minnesota and in the context of this state plan that we do have. And I have 3 questions that I'll share on the screen, and then I'll take it down so that we can have bigger pictures of each other as we discuss. But I'd love to have a conversation with everyone here about these 3 questions. What do we need to do? Both small and large actions. What can we do now? And what do we need to plan to do in the future? And these questions can be in regards to, you can certainly think about your own organization and your own space, but also thinking as a state, what can we do collectively to address these questions? So I'll kick it off with our first question of, what do we need to do now? What do we see as some really important things that need to be addressed today?
I've got a couple thoughts I'll put on the deck, and they span, I think, actually all 3 questions. But as I was listening this morning, 2 things stuck out for me. And it goes back to your second definition of health equity. This notion of changing our systems to allow us to treat people who are seeking service from us differently, to tailor it essentially. And so it made me flash back to when you think about an organization's karma, game plan, culture, there's a series of factors that go into that. It's clarity of mission, it's who your customers are, it's, you know, what your systems are. And one of the main ones is the internal controls that we all have. These tend to show up as policies or administrative directives or memos from the boss or whatever those look like. Well, those controls are all self-chosen. Even in a state agency, there's a great degree of self-choice to those controls. So modifying those controls to allow us to treat people differently who interact with us, and particularly in the private or extremely large organizational sectors, that's hard. Because in the public sector, you've got this notion you're supposed to treat everybody the same. You're supposed to spend the same $3 on everybody. You're supposed to, you know, put everybody in jail for the same crime, whatever your mission is, right? So I think that's one challenge. And then in a very large private organization, just because of the sheer size, you end up with similar stringent controls. So getting this thing on the table, I think we can do it now or start working on it now. So to look at the questions, because it's a self-chosen fate. So changing controls so we can treat people differently, to make it fit the situation, to get the health outcome we want, regardless of the differential on the input side. Mark was going to ask a question.
Yeah, no, Paul, we are resonating and kind of thinking with you. So am I hearing part of your suggestion is maybe do we confuse equity and equality? That there is permission. So in that, you know, revamping those controls that you were talking about, and I think Courtney's been here now 3 hours and maybe is already bumping into some, but Catherine and I for several years. So thinking about our workplace, if we have permission, if we give ourselves permission to take that hard look at those controls, some of which Catherine, we've put in place through memos that I've written, right? Or things that I've said, and saying, wait, instead of $3 per person, it's a responding to, and that's going back to what Devaney and Julie were saying then about that listening in and understanding who our people are from an employer-employee context, but then those we serve in community.
Yes, I think we're talking about exactly the same thing. And I think it's also a matter of keeping track of, are you actually managing the inputs or the outcome? Because, you know, I'm thinking about the classic now illustration of equity and equality with the people trying to look over the fence at the ball game. It drives me nuts because the goal is to see the ball game. So number one, why isn't the first question, why are they outside the fence to begin with? And number two, let's remember that the goal is to get everyone to see the ball game, and everyone focuses on the boxes that people are standing on. Those are inputs. Let's focus on the output and then adjust our controls to manage the output, not to regulate the input. And then the second one is particularly with organizations like that are driven by predominantly some sort of regulatory mandate, whether that's legislative or some other form. Most of those endpoints are designed to solve a downstream problem. You're charged with fixing a downstream problem, so your mandates are downstream mandates. And maybe this is a longer term walk, but what if the Department of Corrections mandate wasn't to incarcerate criminals, but was to prevent people from becoming criminals? You know, so looking at the mandates that we operate under, whether they're self-ascribed or externally ascribed, and asking ourselves, can we redefine that to at least have upstream components to it that would then give us permission to change our controls to start working where we need to go work?
I'd like to offer some thoughts on how I think about what changing controls looks like in an organization, because one thing that we try and focus with equity is a shift in power, right? So if we're talking about working with disabled individuals, they're able to tell us exactly what they need to accomplish whatever outcome it is that we're pursuing. So if we shift the decision-making power, if we shift who has input into, using Paul's words, the controls that we're putting in place, I think we're going to end up with a much better outcome, because the point of the equity is to say, if I tell you what I need and you listen and then we apply it, I'm much more likely to be successful than if you say, okay, I'm willing to do these 3 things, pick one of them. So in the context of like criminal justice, if our goal is to reduce, incidents of crime, reduce the number of criminals, my mind goes to asking those who are currently incarcerated, who are formerly incarcerated, what would have actually helped? What would have decreased your likelihood of going back into jail? What would have decreased your likelihood of kind of engaging with this behavior in the first place? And then saying, thank you for your answers and for giving me understanding the context of why these outcomes are happening. Now let's try and pivot so that a different outcome occurs.
And that has me think back to so many of those words that I wrote down of curious and listening and asking. And so, in that question, what do we need to do now? I think what I'm hearing is creating that space to listen and to ask, to figure out some of those, where those power imbalances or power shifts could take place, to create that space for changes. So maybe thinking about tangible actions that can be taken, how might some of those spaces be created?
Spaces for dialogue or spaces for introspection?
I think both, probably.
Yeah, I mean back on kind of that control side, having within your organization actually taking a step back and with an unvarnished view of what you do, asking yourself, does this make sense? I mean, some of the classic examples of doing that, not related to health equity and policy, but whenever there's a process engineering mapping exercise on the contracting process inside the state, the primary outcome is you are identifying those control points in that process that you've put in that are messing it up. So take that analogy and apply it to your outcomes goals or your efficiency and effectiveness goals, and asking yourself, do you have your own policies that stand in our way? We know this is a very much a subset of the issue, but we do definitely know that we have inequities in the transportation systems and in the crash and injury outcomes in the transportation systems. And we also know that some of the granting processes that some of us interact with are barriers to local agencies participating more in receiving resources to address some of those issues. All right, there's a place we can go.
Right. So with that, I hear a very solid, recommendation of reviewing grant policies to allow for, more equitable distribution of funds. But I also hear in what Paul is saying is this bigger idea of trying to do some culture change, perhaps in a lot of institutions and agencies that allow people to say, I made a mistake, or I'm thinking the policy that I originally thought was a good one 15 years ago isn't good or could be better. And giving people space to say, I changed my mind, I've learned, and we're going to adjust, which I think is something that's hard for people to do, and I think that is a true culture change, is shifting from having leaders and people in power saying, I know what needs to happen, to saying, let's find out what might need to change.
And Mark used a really key word, I think, to add to that earlier: permission. In a job long ago and far away, there was a disaster in Nicollet County. It was a tornado. We had to go to the Nicollet County Board to get them to give their highway department permission to change from the normal maintenance plan to go clear the trees that were knocked down by the tornado. You would think that would be a self-directed change of priorities, but you need to give permission, and that has to come from the top.
Mm-hmm. So we have 3 minutes left. We could have a whole day. We could have days of conversation about this and what needs to happen. And I welcome, we can continue the conversation, and you can certainly feel free to email me, or I think we all have Erin's email address. I don't want to sign her up for a flood of emails, but if you have ideas, please do feel free to send them to us. And the ultimate goal of these sessions is to come out on the other side with kind of a map of how we can address these major factors to get to this healthier and safer Minnesota. So I've taken loads of notes, and I'm going to go back and re-listen to this and learn even more, my second and third time of listening to the discussion, and hopefully pull some actions and ideas that we can all address and think about to change this needle. And so my hope is that we'll be able to share some of those notes with folks who have attended today and with other people that are on our MIVPAC list, so that we can continue this conversation. And maybe we'll even try to get fancy, and Christina's always my go-to on this, but maybe we can get fancy for a document that we can all share and have some continued brainstorm and add and respond to things that people might think of along these lines. Because I think we have a committed group here who just spent an hour of their time thinking about this and learning together. And so I think we could continue this and really try to move, make some changes in this way, and really address health equity. So I appreciate your time for spending this hour with us, and we're committed to continuing this conversation. So thank you for your ideas, and we will see you. We're going to skip December because December is really crazy for everyone. We're going to reconvene in January in 2023, re-energized. To our next topic will be community connectedness, which is really appropriate for this group. We're already seeing some of the great, outcomes that can come from a community and from being connected and sharing these ideas in this space. So this is the first time I get to say this, but happy holidays to everyone as we enter this crazy time. I hope you all take some time for yourself to stay healthy, and we'll see you in the new year, but we will be in touch in between with results from this meeting and plans for the next meeting. So thank you all so much.
Thank you.
So Catherine,
Yes.
will you share the recording of this with a group of people?
Yes.
Okay.
Definitely. In our next, I think Erin's been able to add a link to the recording when we invite you to the next meeting, but I believe we'll have a follow-up email from this meeting, and we'll have a link there for you.
Thank you.
Great.
Thank you. Thank you so much.
And
Wow.
especially